Hello and welcome to Dental XP for this Wednesday webinar. My name is Dr. Sharif Saeed, and I'd like to start off by thanking Dr. Maurice Salama and the Dental XP community for giving the opportunity to younger generations of professionals such as myself and encouraging them to share their work and experiences here on the website. It's truly a pleasure and honor to be here with you today and to have received such an invitation. The topic I'd like to discuss with you today is challenges in managing the peri-implant pink aesthetics. I'll be going through examples from clinical cases in the anterior zone, attempting to highlight different clinical situations or difficulties we as clinicians may face, in addition to different clinical strategies and techniques we have available to us to overcoming those limitations. So for the purpose of this presentation, I'll be touching upon four main topics. Initially, I'd like to talk about the three-dimensional implant positioning and its influence on the final aesthetic outcome of the case. We'll discuss hard and soft tissue augmentation procedures with specific focus on reconstitution of lost tissue volume. And along the course of the presentation, I'd like to share with you the different clinical scenarios we may face and what possible outcomes we can expect when facing ideal sites as opposed to sites that are severely compromised, which require multiple augmentation procedures. So with regards to the three-dimensional implant positioning, essentially we're working with anatomy to simulate the natural appearance of the final restoration. Not only do we want to place our implants in the desired restorative position, but also we need to conform to the available anatomy we have in the site. Therefore, a balance between both anatomical and restorative considerations is really necessary to achieve our desired outcome. And before discussing the buccopalatal positioning of implants, we have to talk about the buccal plate. And we know from the studies that the buccal plate in the anterior segment is less than 1 millimeter in most of the cases. This is compounded by the fact that once we remove a tooth, this buccal plate is going to remodel due to the loss of the bundle bone. In addition, when considering immediate implant therapy, the desired implant position may not necessarily coincide with the anatomical tooth inclination or previous tooth position, which further compromises the situation. So placing the implant in a more palatal position not only facilitates for the restorative dentist the option of having a screw-retained restoration, but also from a surgical standpoint, it allows us to graft internally within the socket or externally as a veneer type of graft to further augment the buccal volume. Also, from a biological standpoint, it has been shown in the literature that a more palatal implant position also allows for less crestal buccal plate remodeling. And if we look at the histology slides to the left, you can see this was done in Botticelli and Lang's study on a dog model. And you can see an implant that was placed more buccal, which is on the left side. You could appreciate the lower level of the buccal plate as opposed to one that was placed more palatal. As far as the apicocoronal positioning of the implant platform, Boozer et al. Recommended a 1 to 3 millimeters from the implant platform to the future gingival margin. Funato et al. Recommended a 2 to 4 millimeter distance from the future restorative margin. And those guidelines are really dependent on the diameter of the implant placed and the width of the tooth to be restored. But 2 to 4 millimeters is generally our range to allow for the restorative dentist sufficient running room to develop the correct restorative emergence and may be erring on the deeper side in sites of immediate implants. As for the mesiodistal implant positioning, conventionally we were accustomed to a 1.5 millimeters between implant and adjacent tooth and a minimum of 3 millimeters between two adjacent implants. In more recent literature, it seems that these numbers have slightly changed. I'd like to point out those three studies. Those are both retrospective and prospective studies, in which both authors found that a distance of 3 to 4 millimeters horizontally between implants and adjacent teeth or between two adjacent implants were associated with a higher prevalence of papillary fill. What was more substantial in their findings was that when the proximity of an implant to the adjacent counterpart, whether tooth or implant, was less than 2 millimeters, the papilla was absent in all cases. Again, those are findings, and the findings of those studies and are not a consensus, but something to bear in mind when dealing with implants in the aesthetic zone. So the three-dimensional implant positioning at the end of the day is essentially a balance between the restorative needs for the case and the anatomical limitations at hand. Moreover, the advantage of correct 3D implant placement is facilitating surgical augmentation procedures if needed in order to enhance and maintain the peri-implant tissue contours. So when we talk about augmentation procedures, the questions to be asked is how much bone do we need, are all defects managed the same, and how do the different available materials and techniques compare to autogenous bone, which was once and may very well be still considered our gold standard for bone augmentation procedures. So how much bone is enough? Spray in 2000 examined the amount of buccal bone remodeling following implant placement at the time of second stage uncovering, and he concluded that if the bone buccal to the implant was 1.8 millimeters or more, there was minimal to no resorption of that bone following implant placement. Grunder and Boozer recommended 2 to 4 millimeters of bone buccal to the implant as well, and the rationale for that was to compensate for any remodeling of the facial bone and minimize the risk of facial soft tissue recessions long term. As for the interproximal bone, we know from the classical studies by Tarnow and Salama that we have a more favorable situation in terms of papillary fill when an implant is placed adjacent to the natural dentition. This is because the level of the papilla is influenced by the supracrestal fibers around the tooth and not the level of bone around the implant itself. So bone sounding and ascertaining the bone height interproximally becomes a crucially important factor in establishing our treatment plan prior to extracting a tooth or even reflecting a flap around the adjacent teeth in order to prevent any inadvertent papillary discrepancies. Not only that, but the importance of preserving the attachment around the teeth has been demonstrated in more recent evidence, showing that the presence of the attachment, whether adjacent to an implant or a dentulous site, allows us the highest level of soft tissue papillary fill when compared to the multiple adjacent edentulous spans. So are all defects amenable to the same type of treatment? We could have localized dehiscences around implants. Those can be usually managed in a more minimalistic fashion. We could have horizontal deficiencies, however, those also come in different forms with different levels of containment, some more demanding in their treatment than others, in addition to vertical discrepancies which may further complicate our treatment in the aesthetic zone. So what technique works best? And currently we have a wide array of materials to choose from. We have a variety of membranes, whether resorbable or non-resorbable, different types and forms of bone substitutes, as well as recombinant growth factors to aid in these augmentations. So what does the evidence say? This review performed by Jensen separated different augmentation techniques with different bone allografts and different types of autogenous bone according to horizontal and vertical ridge augmentations. And what they found for their results was for horizontal ridge augmentation, the range of bone gain was about 2 to 6 millimeters with an average of 4 to 4.5 millimeters of horizontal bone gain and a high implant survival for all techniques. As for vertical ridge augmentation, surprisingly the actual numbers are quite similar. Average bone gain of 3.5 to 4 millimeters with an implant survival also above 96% for all techniques. However, the complication rates in some of those studies went up to 50%, and despite having similar amount of bone volume gains as horizontal augmentations, what renders those procedures less predictable is really the complication rates that are associated with them. So let's move from theory to clinical practice. This patient presented to us following a car accident and fracture of the upper incisors, and we started off with our initial workup of the case, and as you can see from the 3D images and the clinical picture is that we are faced with some significant discrepancies in the anterior segment, to really make it problematic for us to place the implants without any prior augmentations to the site, as the implant positioning and support for those implants will be severely compromised. Also, with the aid of the 3D imaging, we're able to print some 3D sterilizable stereolithic models to help us in planning the augmentation procedure, as well as explaining to the patient what we're going to be doing. So if you take a closer look at the CT scan images, you could appreciate the amount of atrophy that resulted from the previous trauma to the site. There's a lack of adjacent bone walls to help containment or space maintenance of the graft, and so we decided to select a material that has inherent rigid space maintenance properties. And for Maria's case, we decided to go with an allogenic bone block allograft to augment the site. And the evidence of success of allogenic blocks, especially in the anterior maxilla, has been well reported in several publications. The main reservation that usually lies concerning utilizing those allogenic blocks is their lack of vitality. They're basically dead bone. Also, despite their excellent short-term survival rates for implants, the long-term implant survival rates have not been well documented in the literature. Nevertheless, science is constantly improving, and this publication, recent publication in JPRD 2016, seemed to shed some light on this lack of vitality issue. They showed that given adequate healing time, these blocks do remodel and do show signs of bioactive molecular activity as shown by immunofluorescence. The drawbacks of these blocks are a 10% graft failure rate, mainly attributed to technical aspects of block fixation or block contouring. So we proceeded with the surgical preparation of the case, and as you can see, the block we chose here is an iliac crest bicortical allogenic block with a cancellous portion between the two cortical plates. The blocks were contoured and adapted to the models we had beforehand prior to even accessing the site, and this really reduces the surgical time needed for the procedure. Also, in an attempt to enhance the bioactivity of these blocks, we utilized GEM21 as a hydration medium following saline in order to increase the chemotactic and mitotic cellular activity in the surgical site. So as you can see, the site was accessed very similar representation as what was shown on the CAT scan and the 3D printed models. And at that point, I was very curious to see the accuracy of those models that I had printed. And we took some measurements intrasurgical and outside the mouth on the models, and you can see the differences are quite minimal. It depends mainly on the threshold at which you print these models, but despite these discrepancies, it still gives us a good representation of the morphology of the defect and serves its purpose quite well. Also, we have to bear in mind that when we're approaching a large span or large augmentation, our incision designs, we'd like to keep them at least one tooth away from the surgical site to avoid any overlap of the incision margins over the proposed grafted area. And here's a closer look at the site. As you can tell, we're going to be needing some substantial augmentation to restore the lost tissue volume as a result of the trauma to this area. We then proceeded with the recipient bed preparation to receive those blocks, and we start off with selective cortical penetrations to allow for increased vascularity and cellular migration into the wound site. The block was fixated. We used 2-point fixation for both blocks in an attempt to minimize any micro movements or any interruption during the healing process, which may cause or lead to infections or lack of integration of those blocks. Any sharp edges were removed and the block was contoured to have a smooth border, and the irregularities or deficient sites were packed with mineralized bone allograft to further restore the contour in between both blocks. Now, what I did notice that was very interesting and I really liked about those blocks is that provided they're well hydrated, the cancellous portions allows for a degree of compressibility and allows very intimate contact with a high surface area of contact between the block and the recipient site. Even if the contouring of the block was not perfect, you could see how the cancellous portion is very well adapted and soaks up the blood quite well. Following that, a collagen membrane was placed to cover over the grafted site, and tension-free primary closure following periosteal releasing incisions were performed. And I'd like to share with you the early healing of the site at 7 days. You can see we have very good tissue closure over the crestal incision line, and I think we can attribute some of that early healing to the use of the high concentrations of the platelet-derived growth factor that was used in this case. Following adequate healing time, the site was re-entered, implant drilling was commenced, and implants were placed in accordance with our final restorative design or outcome, keeping in mind all the parameters we previously discussed from the apical coronal positioning, mesiodistal positioning between the implants, and the buccopalatal positioning of those implants. And from the side views, you could appreciate the amount of buccal augmentation that was achieved as a result of this procedure, with very good or harmonious blending between the cancellous portion of the allogenic blocks and the patient's native bone. And this is just a pre and post-op comparison with 6 months post-integration CAT scan revealing maintenance of that buccal bone volume following implant placement. Now the question still remains is, how do these allogenic blocks compare to autogenous bone? So fortunately we had the opportunity to have this patient referred to us for replacement of 2 missing lateral incisors that were lost due to a previous endodontic infection. She presented with buccal deficiencies in the sites of the lateral incisors, and if we take a look at the CT scans, you could see 2 very similar defects in both morphology and severity. So following informed consent, we attempted to test our hypothesis in a patient that had no underlying medical issues or a previous history of periodontal disease. And what we wanted to see was how would an allogenic block compare to the autogenous block graft in the same patient with 2 very similar sites. So the sites were accessed, and in this case we had a papilla-sparing incision design. These designs have a little bit of controversy regarding them. They do have the advantage of not involving the attachment of the adjacent teeth, so it reduces the chance of having any papillary recession in the area. But for these types of augmentations, it may not be the best choice, as the incisions may end up over the augmented site, and it also has a small base which may not give adequate blood supply to the flap or the crestal portions and may increase the risk of exposures of these blocks. Nevertheless, we proceed with the case as planned. We went for an allogenic block for the right side and autologous ramus block graft for the left side. And if we look at the occlusal views of the site intraoperatively, they have 2 very similar defects in the area. The external oblique ridge was used as a donor site in this case. The block was outlined and cuts were progressed to the desired thickness distally, mesially, and on the occlusal aspects with the piezoelectric device, and an apical weakening of the inferior border of the block was performed in order to allow green strict fracture and harvesting of a decently sized block with mainly a cortical component. Site preparation was performed in a similar fashion as discussed before, and the blocks were fixated in place. Now, one thing I wanted to mention about these allogenic blocks is that there seems to be a degree of variability from one block to the other in terms of size, cut, cortical plate thickness, but also they have a more brittle nature and less shear resistance, which makes them less forgiving in their manipulation compared to autogenous bone. As you see here, this is mainly a technical error. As you can see, the block was not lagged and was engaged with the fixation screw, which ultimately resulted in fracture of the coronal portion of the block. So lagging of the block is a very important aspect of block fixation, as well as adequate hydration in cases where the cortical plate of the block provided is quite thick, as seen in this case. Also, we opted to use an autologous form of growth factors, namely PRF, which has been reported in the literature to enhance wound healing, angiogenesis, and cellular activity. And for this case, we were able to use it for both hydration of the block and to benefit from the exuded PDGF and VEGF that is produced during its preparation, as well as in its membrane form, acting as a biological barrier, short-term barrier, to cover over our bone graft. A mineralized allograft was used to augment the surrounding areas and the fractured aspect of the block, followed by a PRF membrane over the bone graft for the right side. And for the left side, it has been reported that autogenous blocks have been shown to undergo up to 25% resorption at the time of implant placement, and possibly even up to 60% at the time of abutment connection in certain cases. So here we opted to go for a slow resorbing collagen membrane to prevent any excessive remodeling or resorption of those blocks and particulate graft plate. So we have the closure and 5-day follow-up for both sites, and we know that a prerequisite to ridge augmentations is tension-free primary closure, and that may be easier said than done in some cases. So what I do in addition to the periosteal release is some modification in my suturing technique. I start with an initial deep horizontal mattress suture, as you can see in the top left picture. This is usually a thicker gauge suture, maybe a 4-0 Gore-Tex suture. Then I proceed with vertical mattress sutures more coronally, however not in close proximity to the edges of the flap. And what those mattress sutures do is offset the muscle pull from the margin of my flap, as well as invert the edges of the wound to allow us for good connective tissue to connective tissue adaptation with minimal tension on the flap margin. This also gives me the option to use a finer gauge suture, such as a 6-0 Prolene in this case, in order to closely adapt the edges of the wound with minimal trauma to more sensitive areas such as the wound margins. And you could appreciate the result of using those micro sutures or 6-0 sutures in a GBR case. It really has an influence on the early healing of the site and maintenance of that primary closure. And this is the 5 months post-op for the case, with primary closure maintained for both sites and good buccal bone volume evident in both of the CT scans. At 8 months re-entry, we started with re-entering the allogenic block site, and you could see the allogenic block appears to be well incorporated with minimal resorption of the graft. Following ensuring the graft stability, our implant was placed in accordance to the final restorative margin, and you can appreciate from the occlusal view that we were able to achieve that 2 to 4 millimeters of bone buckle to the implant with a dense cortical plate for added long-term stability of that buccal contour. Our observations for the autogenous site were slightly different. The graft clinically appeared well incorporated, but the surface of this graft appeared to have undergone some form of remodeling, however within normal limits, despite the addition of the membrane to the site. Nevertheless, we were able to achieve sufficient volume to adequately place our implant, as well as good dense bone quality, which sometimes may be tempting for us to try to achieve high initial insertion torque, but we have to take into account that the seam of this graft may be still weak, and caution has to be directed to avoid overstressing the graft site to avoid any fractures that may occur at its weakest link. At that point, we went on and we did an additional buccal contour graft with a slow resorbing zero graft material and a small collagen membrane for added augmentation and to compensate for any further resorption that may occur. As far as clinical observations from this small trial, in terms of integration, both grafts were stable upon drilling and demonstrated good incorporation to the native bone. Autogenous bone has shown more relative remodeling and resorption, which is an indicator really of active biological processes, as opposed to the allogeneic block, which showed minimal resorption and or activity. Handling of the allogenic materials is more sensitive and has a more brittle nature than the autogenous grafts. Density upon drilling was increased or higher in the autogenous block, which could be attributed to the initial high cortical content of that graft. And finally, in terms of time, both both procedures are more extensive and time-consuming than GBR procedures. Both require more time to shape and adapt the blocks, and of course, the additional need of a donor site has to be taken into account for the autogenous graft. So that sparked a new question. Is there a less invasive option to transform a severely deficient site into a more manageable one with less surgical time and morbidity to the patient? Which leads us to our next case. This patient is a senior in college, presented to us for replacement of congenitally missing lateral incisors, and the patient had previously had orthodontic treatment with some relapse, so we had some concerns about the available restorative space. So we performed our mock-up of the case, and he was quite happy with the aesthetics of the laterals as well as the diastema, so we decided to proceed with the treatment. So clinically and radiographically, you could appreciate the rich deficiencies he presented with as a result of the agenesis of his lateral incisors. So again, we had two very similar defects in the same patient, and in this case, we opted to go for a demineralized trabecular bone sponge graft for the right side and an autogenous chin graft for the left side. So the technique we use basically for this demineralized trabecular bone sponge is a full thickness vestibular incision through which we're able to introduce the sponge in the prepared tunnel following induction of the wrap effect utilizing a piezoelectric device. And we were able to obtain some histology from cases. Most of the cases so far have been in the posterior mandible because it allows for easier reflection of intact periosteum, but we're starting to apply this in the anterior maxilla, and I'll share with you our preliminary results of some cases. So this is a side-by-side comparison to make it easier to visualize the differences. The incision design for the sponge graft is a simple crestal incision that's extended sulcularly around the adjacent teeth. For the autogenous block, we have to increase or perform sufficient exposure by extending our flap through a vertical releasing incision. You can appreciate also the evident buccal concavity and horizontal deficiency present in the site, with also a palatal component to this defect that's not really clear on these slides. We then proceed with extending our reflection or our pouch for the right side, and we have to bear in mind not to extend our pouch too far mesially, distally, or even in the apical direction to allow for sufficient stabilization of this sponge. The piezotome is then utilized to perform our cortical penetrations and induce a state of transient osteopenia, which seems to influence the mineralization of the sponge. And as you can see, the sponge is provided in a compressed dehydrated form, and all it takes to hydrate it is really just placing it in the recipient site for a few minutes, which allows it to expand. Now, as you can see here, that the sponge has an inherent elastic property, so it has the advantage of maintaining the space, but also it's sufficiently compressible to allow for primary closure without the need of periosteal releasing incision, and this obviously reduces the patient morbidity and discomfort associated with all bone grafting procedures. For the left side, we proceeded with obtaining our measurements and accessing the symphysis area through a mucosal horizontal incision. We then proceeded with outlining our block utilizing a piezoelectric device, and our osteotomies are carried out past the cortical plates of bone to allow freeing up of this block and obtaining a corticocancellous graft to augment the site. And as you can see here, the graft is harvested uneventfully with a cortical and cancellous portion. Again, the side-by-side comparison shows you the difference of the required steps between both procedures: harvesting, shaping, and fixation of the block, as well as the addition of particulate grafts, membranes, and releasing incisions make these procedures very time-consuming and technically demanding compared to a simple pouch and insertion of that sponge graft. And this was the closure for both sites. And again, all it took for the sponge area were 3 simple interrupted sutures with no releasing incisions to attain and maintain primary closure for the period of the healing. So when the patient returned for the 6 months follow-up, the clinical contours of the sponge site seemed to have responded better than the block graft area. However, when the CT scan was taken, you could clearly see that the bone volume achieved by the block graft is significantly greater than the sponge. Having said that, this is a demineralized sponge and requires usually about 7 to 8 months to start showing evidence of adequate radiopacity, so this is something we have to bear in mind. Also, putting aside the total amount of bone gain achieved, the ridge morphology for the sponge site is now more conducive for us to place the implant, and we're able to render a severely atrophic site into a more manageable one. So this is a close-up of both sites, and I'll share with you the re-entry for the sponge graft for this case. So if we take a look at this critically, this is not an impressive amount of bone volume gain. It's not sufficient for buccal contour maintenance. But if we compare it to the pre-existing situation, you could appreciate complete fill of this horizontal defect on the buccal aspect. And now we can employ our current available technologies to allow for slight expansion of the site as necessary. Also, we were able to obtain a core biopsy of the site to evaluate the integrity and the viability of this bone. However, the area where we wanted to analyze of the sponge was too buccal to the desired implant position, so we extended our core more apical, and in order to ensure that the sponge was included in the core, but also we had to employ some densification process to both increase the primary stability of the implant in addition to slightly expanding the ridge. And as you can see here, following implant placement, we have sufficient buccal bone volume, actually not really needing a contour graft. However, we did proceed with one just to be on the safe side for this case, because we do not know what the remodeling of these sponges are on the long term. And then primary closure was finally attained. So no membrane, no release, minimal surgeries, but we were able to fulfill the requirements to allow us to place our implant successfully in the correct restorative and anatomical position. So this could possibly be a minimally invasive option to aid in making a severe defect more manageable. Maybe employing a membrane in this case could improve the amount of buccal augmentation or augmentation achieved. And again, this is something in its infancy. We're still refining our techniques, but I just wanted to share with you what we have so far. So the problem now becomes, after advancing these flaps, we distort the soft tissue architecture available, and the more extensive the augmentation, the larger the discrepancy we have to deal with. So addressing the soft tissue is really crucial for the final outcome of the case. And for this part of the presentation, I'll be discussing with you the importance and timing of soft tissue augmentation procedures, management of mucogingival discrepancies following extensive bone augmentations, and dealing with significant defects which require both simultaneous or concomitant hard and soft tissue rectification. And the importance of soft tissue thickness around dental implants for maintenance of function, aesthetics, and underlying support has been widely reported on in multiple publications. The ones shown here are to shed some light on the influence of soft tissue thickness on the aesthetics and marginal tissue stability, especially when these implants are not placed in an ideal position or in the aesthetic zone, where soft tissue aberrations may pose a restorative and functional problem for the patient. So when can we perform our soft tissue augmentations? One of the options is in this case following implant integration. So implant was placed and this is the time of second stage uncovering, and you could see that we have a buccal soft tissue deficiency in the site of the upper right central. So provided we have sufficient information from the CT scans and we know that we have enough bone around this implant, really we don't need to reflect any flaps to assess the bone around the site. All we need to do is a small slit incision or punch, if you will, to allow access to the implant and to the restorative components. So we then proceed with taking the impression. The impression coping was placed and the impression was performed to help fabricate a temporary crown for this implant. Following which, we continued with a split thickness or supraperiosteal tunnel on the facial aspect of the site. And you can see we try not to involve the papillae in this area. If we can minimize the amount of disruption to the architecture we have, the better. And a connective tissue graft was harvested from this right palate in this case and allowed to be introduced into this tunnel. One of the issues we may have with connective tissue harvested from the palate is obtaining a graft with a high adipose content. This may render the graft less stable and more prone to shrinkage over the long run. So what we did here is, following introduction of the apical portion of the graft, we planned on folding the coronal portion to allow for increased thickness in the site that required the most augmentation. So we could see that the graft was secured and doubled in thickness to compensate for any shrinkage that may occur with the aid of a marionette type of suture, in addition to the healing abutment to further secure the graft in place. And this is the immediate post-op with two suspensory sutures that were performed on the papillae just to maintain that height of the soft tissue in the area, even though they were not involved in the tunnel preparation. And if we evaluate the early healing of this case, this is at 3 days post-op, you could see a very favorable tissue response in the area due to the limited amount of trauma that was performed to the site. Again, at 5 days and 12 days, showing good tissue integration and healing around the temporary crown. And at 2 weeks following suture removal, if we take a look at the occlusal aspects, you could see that we were able to create a more natural emergence of that implant restoration. So at 5 months post-op, the patient returned to finalize the case, and although we experienced some shrinkage of the graft, we were still able to achieve adequate buccal augmentation with a relatively natural emergence compared to the adjacent dentition. So this case is an example of a corrective procedure, but what if we were able to prevent such collapse to start with? We might be able to cut down on the number of surgeries for the patient and maybe improve the final outcome. So another option or time to augment the soft tissues is in conjunction with implant placement. And I use this case just to demonstrate how preservation of the natural tissue architecture can significantly influence our final result, with less tissue manipulation and less restorative manipulation. This patient presented to us for replacement of tooth number 8, and following crown fracture and severe intercanal decay, this tooth was deemed non-restorable. And you could see we have a high lip line with a thin scalloped architecture, which poses a high risk of recession following tooth removal. So the tooth was sectioned and elevated with minimal trauma to the soft tissue, and the implant was placed with good primary stability, so a decision was made to immediately provisionalize the case. And in an attempt to minimize any possible tissue recession as well as augment the soft tissue thickness in the area, we proceeded with a connective tissue graft in combination with a tunnel approach, as shown in the case prior. The only difference is, given the thickness of the tissue and the root prominence in the area, it becomes more challenging for us to perform a complete split thickness dissection. So we use a combination of microsurgical blades and tunneling instruments to perform a split/full thickness dissection and decrease the likelihood of any tissue perforation. So the connective tissue graft was harvested from the palate and introduced into the tunnel with the guidance of the marionette suture that was stabilized apically. Also, grafting of the gap between the implant and the buccal plate was performed, and the area was provisionalized. And if we look at the healing at 6 months, you could appreciate the quality of the tissue around this implant and the maintenance of the tissue architecture as a result of the provisionalization. But also throughout the healing time, we're able to maintain the gingival margin levels with minimal soft tissue recession when compared to the adjacent central. And again, a close-up view of the healing at 6 months, you could appreciate the stippling around this implant and the health of the tissue in this area. So once the crown was removed, you could immediately see the advantage of temporizing this case. It allows really for minimal adjustments to be performed prior to finalizing, as the soft tissue architecture has already been developed and maintained. And in this case, the plan was to veneer the adjacent central for aesthetic purposes. This was done in accordance to our initial wax-up of the case. The veneer preparation was performed as well as the abutment try-in, and this is the result we were able to achieve immediately following provisionalization of both central incisors, with an adequate aesthetic outcome that required really minimal restorative tissue development and a minimal amount of surgeries. And an additional advantage of enhancing tissue thickness in a thin biotype case is that it really gives the restorative dentist flexibility in terms of materials for their abutment selection without having to worry about any show-through of the restorative components through the tissue. Also, if we take a look at the occlusal views, you can appreciate that we're able to achieve an increased amount of tissue volume, which would aid us in adequate long-term marginal tissue stability around those implants. So preventive or preemptive augmentation in high-risk cases may have significant benefits for the final aesthetic outcome of the case. And going back to one of the downsides of extensive bone augmentations is the question is, how do we manage this vestibular depth reduction and lack of keratinized tissue in the area? So let's look at the available options. And really, we have numerous treatment modalities for these types of discrepancies, ranging from apically positioned flaps alone or in combination with either autologous or allogenic materials to aid in enhancing the soft tissue quality in the site as well. Now, with autogenous grafts, we have the obvious downside of related donor site morbidity, so maybe in cases with larger discrepancies, a choice of a tissue substitute may be less invasive option to the patient. And what we chose to proceed with in this case is utilizing a mucograft or a porcine collagen matrix or membrane that is used in conjunction with an apically positioned free gingival strip graft, so a 2 mm width free gingival graft, as reported by Urban et al. And I'll share the steps of the procedure with you. So we perform our incisions in keratinized tissue all around the site, extending our dissection sufficiently to allow for adequate apical positioning of our flap margins. Now, unlike alloderm, this material is not hydrated prior to the placement, as it becomes quite difficult to stabilize it and becomes very flimsy if it's overly hydrated. So what we do is we simply place the material over the bed preparation and allow it to soak up the blood and be hydrated by the natural bleeding in this area. And as you can see, we try to stabilize it to stabilize the membranes to the surrounding margins as much as possible, but also if we need to, we stabilize or connect the membranes together if we have larger areas to deal with. And at that point, 2 free strip grafts were harvested. Again, those are 2 mm in width, with a 2 mm distance between the borders of both grafts to allow for adequate epithelialization and thus a healing time for these areas. And the function of this graft is really to help the phenotypic induction of the mucal graft by stimulating its keratinization from the apical aspect. You can see here we will use 2 resorbable sutures to fixate the free gingival graft apical to the mucal graft, and the final suturing with crisscross periosteal sutures to decrease any mobility of the area and decrease the amount of dead space between the grafts and the recipient bed during the healing phase. So how does it heal? The patient returned following 1 and 3 days because the Peri dressing was not holding in place, and over the first few days you could see the initial clotting and fibrin formation over the grafted site. At 1 week, and I wanted to correlate the clinical findings to the histological healing of mucal graft. This was reported by Simeon in a pig study. You could see at 1 week superficial epithelialization from all the boundaries around the graft, from the apical, coronal, and mesiodistal directions, with the mid portion being the last still to revascularize or repopulate with the epithelial cells. And at 2 weeks, again, good tissue integration and blending of the membrane with the surrounding tissue, and at 30 days demonstrating increased vestibular depth with very nice tissue blending, and the patient reported minimal discomfort throughout the healing for this entire case. So as an overall review of the healing, you can see the amount of vestibular increase achieved immediately post-op, and this is the 1-month follow-up revealing maintenance of this vestibular depth and improvement of the tissue quality in the area. But at 6 months, this is what happens, and this is one of the downsides of mucal graft, is that it has been shown to undergo up to 60 to 70% of shrinkage for the mucal graft alone, and about 45% of shrinkage for at 12 months when combined with the free gingival graft as reported by Urban in his study. Nevertheless, we were able to achieve sufficient vestibular depth, sufficient keratinized tissue around these implants, and we learned from our mistake, taking into account this anticipated amount of shrinkage, and the case was uncovered and provisionals were placed to start the soft tissue sculpting process. So as you can see, with defects that are less demanding in terms of their augmentation requirements, we are able to achieve a decent result with minimal tissue manipulation. However, as the defects become more complex, the augmentation demands and number of procedures needed are also increased, which may eventually compromise or have a negative impact on the final aesthetics of the case. So let's take a look at a more extensively involved or compromised site. This patient presented to us following a failed implant in site of the upper right central incisor with a resultant horizontal and vertical ridge deficiency. To further complicate things, the vertical defect was mainly involving the papilla area between the two centrals, which is already an unfavorable situation to start off with. So we discussed the plan with the patient, including having a bridge as an alternative, but she wanted to proceed with the replacement of the right central with simultaneous augmentation of the site. So the site was accessed and you could appreciate the extent of involvement of that area. We proceeded with the implant placement as planned in the site of the previously failed implant at the same level of the adjacent implant placed. And in addition, we used a 2 mm healing abutment on these implants to tent our membrane to the level of the interproximal peaks of bone on the adjacent laterals. So that part was performed, and then in order to graft vertically around this area, sometimes we are faced with the challenge of the nasopalatine bundle and or canal in this site. And in such a case, it is in our way if we're trying to attempt any augmentation procedure in the area. So what options do we have to overcome this problem? Now, we could initially start by curetting the contents of the canal and grafting it and treating it as a socket, if you will. We could hollow out the canal and place an implant, and both of the previous techniques are associated with a higher rate of neurosensory problems. So the option we decided to go with for this case is partial lateralization of the nasopalatine canal or bundle, and this is a way we reflect the bundle as part of the palatal flap, and we introduce the membrane to further isolate this bundle from our graft material so we don't have any soft tissue ingrowth into our grafted site. This technique has also been associated with less neurosensory complications as opposed to the other previous techniques mentioned. So as you can see here, the contents of the canal are reflected as a whole with the palatal flap and isolated away from the graft with the aid of our membrane. We use 2 fixation mini screws on the palate to fixate the membrane and allow us to use it as a wall, if you will, to pack our bone graft against. Also in this case, we used a tenting screw in between the 2 implants to support the area of the future inter-implant papilla that we know might have some deficiencies or is relatively harder to regenerate or reform. And this is the site upon 6 months of healing, and you can appreciate the soft tissue closure maintained over that site with radiographic bone formation evident on the radiographs. So at 6 months, the site was re-entered and the membrane was removed to examine the quality of the augmented bone and integration of those implants. You could clearly see that some of the portions of the graft overlying the implant healing abutments and tenting screw were not fully consolidated and were removed, but the buccal aspect of the augmentation revealed good density of bone. We removed the tenting screw and the implants were indexed to allow us to have a provisional ready for the time of second stage uncovering, and delivering 2 longer healing abutments in the site was then performed, in addition to some xenograft bone material that was placed in the sites of the voids to fill the area of the tenting screw and any irregularities we may have had. And knowing that we're going to be faced with the risk of inadequate tissue height in between 2 papillae, We proceeded to augment the soft tissue with a connective tissue graft in this area, and this is to further enhance the restorative outcome or the aesthetic outcome of the inter-implant papilla. You could also see here that this graft was fixated with a crisscross periosteal suture to allow for adequate stabilization of this graft prior to suturing of the flap. So again, resulting from those augmentations, we sometimes end up with significant discrepancies of the mucogingival junction. And in this case, we proceeded with the same technique as shown before, with an apically positioned flap to allow restoration of the vestibular depth, keeping a band of keratinized tissue all around the site boundaries. The mucograft was then sutured. This time we increased the width of the mucograft to compensate for any anticipated shrinkage we may have, as well as increasing our suture adaptation in order to decrease any micro movements that may compromise the wound healing and contribute to this shrinkage. And if we take a look, this is again the compressive sutures with a crestal view showing very intimate adaptation between the mucograft and the tissue. Also 2 weeks healing, showing a nice tissue blend of the area, and uneventful healing with minimal pain or discomfort. So looking at our treatment, we were able to improve not only the lost tissue volume of this site in both horizontal and vertical dimensions, but greatly improve also the tissue quality, which is essential for maintaining health and function around these future restorations around those implants. And moving on to our final case, this patient presented to us following implant placement in sites of number 9 and 10 with a history of complications to the area. You could see that the provisionals were extended to occupy the site of tissue loss, and once we removed the provisionals, we were able to clearly see the extent of the defect and involvement of the implant in the central incisor region. So following a long conversation with the patient, we recommended a bridge, maybe with possible soft tissue grafting or pink porcelain, but the patient was really determined or insistent upon finishing this treatment with implant therapy as he started off with. So we proceeded with exposing the site to evaluate the implants, and sure enough, the implant in the central incisor had completely dehisced or missing palatal bone wall in addition to buccal dehiscences. So a decision was made to remove this implant. The one in number 10, however, seemed to have a thin layer of bone on the buccal to that implant, so a decision was made to augment over both sides. I did not want to be personally the one who removed the implant and was not able to achieve anything after. So a cytoplast membrane was used with a mineralized bone allograft and 4 fixation screws to ensure stability of this graft during the healing period. And this is the pre-op situation, and this is our 6 months post-op of the case. Now, if we take a look at the CT scan and at the clinical pictures, we were able to achieve some clinical bone volume. However, from an aesthetic point of view, this really puts us still not in a favorable condition, because we are way below the height of the adjacent papillae of the adjacent teeth, and we have a lot of soft tissue management we need to perform before this case can be considered anywhere near aesthetic. So following ample healing of this bone graft, we proceeded to remove the membrane, and you could see the implant that was previously exposed or dehisced on both sides is now completely covered by the newly regenerated bone. Implant placement was performed according to the restorative guide, and then a secondary augmentation was done with supracrestally augmenting with a xenograft material as well as buccally as a form of contour graft and space maintenance. We're not looking for vital bone formation, we're looking for something to maintain the space in that area. Collagen membrane was used, and then following that a connective tissue graft was harvested from the palate and the site was sutured. So this is after 4 months of the secondary augmentation. You could evaluate the pre-op x-rays versus the post-operative x-rays of this area, and although we were able to attain some improvement, we still have some deficiencies that the patient was aware of, and at that point we could resort to a pink porcelain in the papillary area, which can be better masked to a certain extent. Also, we were developing some recession on the right canine lesion, so we decided we will go for one more procedure, and the patient was on board. And if it works out, it does. If not, we have the backup of the pink porcelain. So the site was exposed once again, and you could see the architecture that was formed by the supracrestal augmentation. You can see the healing abutments were placed at the height of the interproximal peaks of bone, and we proceeded with a full thickness flap reflection up to the bucco-occlusal line angle of the bone. Following that, we went split thickness to allow for sufficient relaxation of this flap and coronal mobilization, because once we've had multiple reentries of a site, we have a lot of dense scar tissue that does not release. So the key is here to continue with split thickness dissection as much as you can, and in a more superficial fashion as much as you can, to avoid any of this dense scar tissue formation that is more close to the osseous structures. Again, this is the occlusal view of the augmented buccal bone and interproximal bone peaks, and we utilized another connective tissue graft from the palate in order to fully augment the site, and the suturing was performed in the same manner I discussed earlier, with a combination of horizontal, vertical mattress sutures as well as a continuous nylon suture to offset any muscle pull and invert the edges of this connective tissue of the connective tissue portion of these flaps to allow for very nice adaptation and healing. So the implants were uncovered and the provisional was fabricated for this case. So let us evaluate this case critically. You could see the more surgical procedures performed, the less favorable the tissue response was, in addition to the added trauma to the patient, of course. Also, we lost the papilla between the two central incisors due to the multiple re-entries of the site, so trying to fix one problem, we ended up with another, also with some clefting on the papilla between the right central and lateral incisors. However, what we were able to accomplish in this case is augment a largely deficient site in the anterior maxilla in a patient with a high lip line, in which if we had gone for pink porcelain, we could have very well had the challenge of being unable to mask the interface of the pink porcelain with the edentulous ridge. So our augmentations were not only aimed at the aesthetic outcome, but also for long-term functional and tissue stability around those implants. And with those corrective procedures, we were able to achieve a relatively harmonious result with good integration between the white and pink aesthetics, despite the minor soft tissue discrepancies that we were left with. So for our concluding remarks, in anterior implant therapy, a combination of biology, function, and aesthetics have to be continuously balanced throughout our treatment, but at the same time always delivering treatment that is suitable for and tailored to the patient's demands as needs, and needs are really necessary. Surgeries, like in the last case as an example, are not something that the majority of patients will be able to undergo or be willing to undergo, but if they do, careful planning and sequencing of treatment is crucial for successful outcomes. And finally, the more we're able to preserve of nature, the better our results can become with minimal surgical manipulation. I'd like to thank you all for your attention. I originally come from Cairo, Egypt, but I consider Boston a second home for me, not only for the years I spent here, but I was fortunate enough to graduate from the same program as my father did 40 years later. So I'd like to thank you again for your attention. It's been a pleasure to be with you, and please feel free to send me any emails or any comments regarding the presentation. Thank you.